Yes, ma'am. I'm not able to hear you well. Are you able to hear me well?
Yeah, sure.
Okay. So on behalf of Dr. Jayalakshmi today, I'm starting to introduce this session, which is a session on drug and kidney. So drugs are very important. It not only plays a very important role in acute kidney injury, but also has got some implications in causing chronic kidney disease too. So I feel very much privileged and proud to have a young dynamic nephrologist on board who's going to speak on this topic. Dr. Sandhya from SRMC. She has done her nephrology DND from Mujibhai Patel Urological Institute from Gujarat, 2018 to 2021. And her general medicine was from CMC Vellore. Yes, was from MMC Chennai. And so we have young dynamic person who has got a lot of interest in nephrology. And she's one of the important, she has got some few publications to her credit too. Also a recipient of a Young Nephrologist Award for Best Clinical Science Abstract at WCA in 2021. So without coming in between the speaker and the audience, I'll just hand over.
Thank you, Ranjini ma'am, for that lovely introduction. Without any further ado, I'll get on with the topic of drug-induced kidney diseases. So with the ever-increasing armamentarium of drugs which are available to us today, this is a problem that is only going to keep increasing as the years go by. So especially with the newer chemotherapeutic agents, along with the persistent presence of the over-the-counter medications, as well as the poorly characterized herbal traditional medications, this drug-induced kidney disease is only going to increase further and further as the days go by. So I will be taking everyone on a journey through drug-induced kidney diseases. We'll start off with an introduction, then the phenotypes and their definitions, pathogenesis and certain specific drugs and their effects on the kidney, and a conclusion. So let me start off with this slide. And, I'm sure a few of you might have seen this 2004 Oscar-winning film. Does anyone know how this is connected to the current? So I'll tell the answer to this question. So the person who was the subject of the movie, Howard Hughes, is a famous aviator who was addicted to multiple analgesics for a 30-year period. And it was found during his autopsy that he had features of chronic kidney disease. And he's one of those prominent personalities whose death was attributed to the then called phenacetin kidney. So this was his story, which was put forth in this magazine. So the era of kidney disease is thought to have started in 1953 when this first description of the phenacetin kidney was put forth. And they've described the papillary necrosis which occurs in patients who had been consistently taking multiple analgesics and the combination analgesics containing phenacetin. We thought that it started in 1953 doesn't mean that it started in 1953, because the drugs have been around since time immemorial, especially the drugs like heavy metals, mercury, and all of these have been in use since several centuries. And it has always been known that these are all thought to be poisonous and can have poisonous effects on the kidney. For example, in the 1920s, these are beautiful hand-drawn diagrams of the effects of mercury and silver salts in the kidney, which were then used as therapeutic agents. We can see the tubular necrosis and all, and glomerular basement membrane showing silver staining in these pictures, and this was recognized as early as the early 1920s. Coming to the current era, do we know how frequent drug-induced kidney disease is? Drugs can produce a wide spectrum of manifestations. They can be acute or chronic toxicity. They can affect any compartment of the kidney. There are no standard definitions for drug-induced kidney disease. And many times we may miss the manifestations of drug-induced kidney disease, especially when there's a short history of drug exposure. So there's a different challenge in assessing the incidence, the severity, and the long-term consequences of drug-induced kidney disease. Most of our data on drug-induced kidney diseases comes from prospective studies on AKI. So we don't have much data on chronic toxicities. We do have some data on acute toxicities. So it is thought to account for about 14 to 26% of hospitalized AKI in adults and accounts for about 16% of the AKI in the pediatric population. As far as Indian data goes, it can account from anywhere from 7.4 to 20%. 20 number coming from a study by Jai et al. In 1995. How does developing countries like ours differ from developed countries in terms of these drug-induced diseases? If we're a little bit different from the developed countries, much of the drug-induced diseases happen in hospitalized patients. Here we have a significant contribution from the traditional medicines. If you divide AKI into something as medical, surgical, and obstetric causes, a large percentage of medical causes of AKI in tropical countries would be due to these traditional medicines. However, there is a changing trend very similar to developed countries, even in India. We are seeing more incidents in hospitalized patients. We are seeing changes in the causative agents. Earlier, it used to be predominantly due to antibiotics, NSAIDs, ACE inhibitors, antivirals, and the newer chemotherapeutic medications. Coming to chronic nephrotoxicity, as I already said, it's always difficult to predict the chronic nephrotoxicity. We have these organoids and kidney on chip models which can detect acute nephrotoxicity of the drugs during the development stage itself. It is said that the kidney related safety failures account for about 10% of the drug failures during development. But it's difficult to predict chronic toxicity, which is why we need alerting systems and regular review of medications. Another difficulty with determining chronic nephrotoxicity is that CKD patients often have polypharmacy and it's difficult to attribute the toxicity to any single drug. There is also an underreporting of the over-the-counter medication use. For example, when we look at this German study, when they asked patients, they reported analgesics in less than 3% of patients. But when they checked the drug metabolite levels in urine, about 10 to 18% had ibuprofen, which is a common problem even in our setting. So the use of such pharmacometabolomics may be useful in this setting to determine chronic toxicity. So we know how with AKI, the standardization of definitions and the criteria helped in better reporting of acute kidney injury. So in a similar setting, Dr. Ravi Mehta et al. Actually tried to bring about consensus definitions for drug-induced kidney diseases as well. And so they divided the drug-induced kidney diseases into 4 phenotypes: acute kidney injury, glomerular disorder, tubular disorders, and nephrolithiasis. And for each of these phenotypes, they gave a primary and a secondary criteria. I don't want to go too deep into each of these primary and secondary criteria, but I can tell you briefly that acute kidney injury includes acute tubular necrosis, acute interstitial nephritis, and osmotic nephrosis. The glomerular disorder involves any biopsy-proven drug-induced glomerular disease, along with proteinuria and an active urinary sediment. Nephrolithiasis can include crystalluria, nephrolithiasis, as well as any stone with or without obstruction. And tubular dysfunction can include any of renal tubular acidosis, Fanconi syndrome, SIADH, diabetes insipidus, and phosphaturia. It's also important when we're talking about drug-induced kidney disease to establish causality between the drug and the kidney nephrotoxicity. So it should fulfill this Bradford-Hill causal criteria that the drug exposure should be within at least 24 hours of the event. There should be a biological plausibility which explains that the drug can cause such toxicity. We should take into account concomitant risks and exposure to other nephrotoxic agent. And there should be the strength of relationship between the drugs that can be fulfilled by when we apply the primary and the secondary criteria for the phenotypes. Once we determine the phenotype of drug-induced kidney disease, then after that we can further divide them into 2 types, that is type A and type B. Type A is a classic example of glycoside nephrotoxicity. These are dose-dependent reactions which can be predictable from the known toxicity of the drug. Whereas type B are idiosyncratic, they are unpredictable and they may not be related to the pharmacology of the drug. For example, when we take proton pump inhibitors and acute interstitial nephritis, this would be classified as a type B adverse drug reaction. Much of the data of type A reactions comes from case reports and follow-up of trials and the post-marketing surveillance studies and also retrospective studies. But type B is mostly present in the form of case reports and it's difficult to determine the incidence. Why is it important to know whether it's type A or type B? Type A can be managed by just dose reduction, sometimes may need withdrawal. but type B will almost always require drug withdrawal. They again, this Ravi Mehta et al. Group also further divided the subsets according to the time course. I think that part is one missing. And basically it is divided depending upon the time course into acute, subacute and chronic. The subacute if it is less than 7 days, acute if it is less than 7 days, subacute between 8 to 90 days, and chronic if it is more than 90 days. So again, we have the classic examples. Aminoglycosides and amphotericin B can cause acute types. Cisplatin is a subacute type of nephrotoxicity. Lithium produces a chronic nephrotoxicity. So what is the advantage of this phenotype standardization? It gives us a uniform method to record such drug-induced adverse events and helps us to define the epidemiology of DIKD better. So this will in turn help the pharmaceutical industry in terms of drug development. It will help regulatory agencies in surveillance of safety of medications. And of course, it will help physicians and patients and enable us to recognize DIKD earlier and better. So this is how they have given the classification. I'll take two classical examples of NSAIDs and vancomycin. So if an NSAID, if a patient on NSAID develops a hemodynamic type of AKI, then we would classify it as AKI phenotype type A, whereas it can be acute or subacute. Whereas if the person develops an acute interstitial nephritis due to NSAID, then we would classify it as AKI phenotype type B. Similarly with vancomycin, if a person on vancomycin develops a typical vancomycin nephrotoxicity with acute tubular injury, we would call it as AKI phenotype type A. Whereas with if the patient with vancomycin develops the typical features of AIN with eosinophilia, eosinophiluria, rash, etc., with acute interstitial nephritis, that would be classified as AKI phenotype type B. So why the kidneys? Why is it that the kidneys are affected other than the other organs in the body by these drugs? So this lies in the general physiology of the kidney. The kidney receives nearly 25% of the cardiac output from the heart. So there's a high drug delivery to the kidneys. Secondly, the certain parts of the kidney like the thick ascending limb of loop of Henle have very high metabolic rates and they lie in a relatively hypoxic environment. So they are very susceptible even to slight renal insults. Third mechanism is that there are certain transporters in the kidney, as we can see here. In the proximal convoluted tubule, there are transporters on both the luminal side and on the basolateral side, which will help in concentrating these drugs inside the cells and which in turn causes the toxicity. Fourthly, the medullary interstitial concentration gradient increases the local drug concentration and it also predisposes the kidney to toxicity. And last but not the least, we have to remember that the kidney is a site for biotransformation. The kidney contains cytochrome P450 enzymes, flavin-dependent monooxygenases. So it will result in generation of toxic metabolites and reactive oxygen species, which can further damage the kidneys. There are also certain other patient-related and drug-related risk factors. So what are the patient-related risk factors? It's important to recognize these so that we know that these patients are at high risk of drug-induced kidney diseases. So older age patients, female sex, those with pre-existing CKD, certain pharmacogenetic changes like those with certain polymorphisms in the cytochrome P450 genes, persons with underlying nephrotic syndrome and cirrhosis, and these are all patients who are at a higher risk of drug-induced kidney disease. Two important factors are volume depletion, because volume depletion does predispose significantly to higher risk of drug toxicity, and certain metabolic factors like hypokalemia, hypomagnesemia, hypercalcemia, and either acidic or alkaline urinary pH, depending upon the drug, will also increase the risk of toxicity. What about drug-related factors? What are the drug-related factors? First factor will be the duration of exposure and repeated exposures. So that would increase the risk of toxicity. The inherent nephrotoxic potential of the drug and the potential of the drug to elicit immune response and cause inflammation will also be one of the important factors. Then using a combination of nephrotoxic drugs will further increase the risk. Soluble drugs can produce crystals which will also cause nephrotoxicity. And certain combinations of drugs will produce competition for transporters and thereby leading to accumulation of these drugs and thereby leading to toxicity. So when I started off reading for this topic, I actually found enough material to cover 2 hours. But okay, I am not going to take for 2 hours. I can see the look of panic on everyone's faces. So I will limit myself to certain drugs which have fascinated me in their mechanism of nephrotoxicity, and which pose kind of a clinical challenge when we are managing such cases. So first of all, let me start off that these drugs can produce a form of pseudo AK by by interacting with certain mechanisms in creatinine secretion. So first is cimetidine, the long known inhibitor of creatinine secretion. But there are certain other drugs which we should be aware of, like trimethoprim, which is commonly used as part of Septran in our transplant patients and so on. Dronidarone, then cobicistat and dolutegravir, which has now become one of the backbones of ART, then tyrosine kinase inhibitors. All of these can increase the creatinine secretion through the proximal tubular cells. Then we have cefoxitin or cephalosporin, which is actually a chromogen for creatinine by the alkaline pick rate method. So this can also give a falsely high creatinine value. Flucytosine can interfere with the enzymatic assay. We should know that corticosteroids can cause a catabolic state, which can lead to an increase in the creatinine levels. Also, certain formulations of dexamethasone contain creatinine in them as an excipient. Fenofibrate can increase the production of creatinine. So all of these will produce a form of pseudo-AKI. There is also the hemodynamically mediated AKI. I think there is a picture of the glomerulus which is missing. But let me say that anything which produces vasoconstriction of the afferent arteriole or vasodilatation of the efferent arteriole would produce a decrease in the GFR and thereby producing a hemodynamically mediated AKI. So NSAIDs, SGLT2 inhibitors through their effect on the tubuloglomerular feedback, and calcineurin inhibitors. All of these cause afferent arteriolar constriction, whereas the ACE inhibitors and ARBs cause vasodilatation, that is, they inhibit vasoconstriction of the efferent arteriole, and all of these can produce a hemodynamically mediated AKI, especially when given in combinations. So now we'll come to the first phenotype, that is drug-induced acute tubular injury. So this is the classic example of drug-induced nephrotoxicity. Whenever we talk about any DIKD, it will not be enough if we don't touch upon aminoglycosides. So we know aminoglycosides are polycations. They undergo glomerular filtration, and in the glomerular filtrate, in the luminal surface of the cell, they undergo megalin-mediated endocytosis. When they are endocytosed, these are polycations, we should remember. So they will neutralize the negative charge inside the lysosomes. These endosomes will then bind and form lysosomes, and they will inhibit these enzymes like phospholipases, and they will also go and neutralize the negative charge of the phospholipids on membranes, and thereby cause membrane aggregation. Membrane aggregation will damage the lysosomes and release and cause rupture of the lysosomes and release of acid hydrolases and other enzymes present in the lysosomes, which can produce cell necrosis of the proximal tubular cells. These membrane aggregates are what are seen classically as myeloid bodies in electron microscopy, and we can also see the distended lysosomes in this image of the electron microscope. About 10 to 25% of exposed persons to aminoglycosides will develop nephrotoxicity. It produces a non-oliguric type of AKI, usually at around 5 to 7 days after starting the medication. It can also produce a Fanconi-like syndrome. So how do we prevent aminoglycoside nephrotoxicity? So in order to know this, we need to know the pharmacokinetics of aminoglycosides. We all know that it has a concentration dependent killing. So what is important here is the peak above the MIC rather than the time above the MIC. So we need good peak concentrations. So how to make use of this is to use a high dose with an extended interval. So in this, we would prefer once daily dosing instead of repeated dosing. So it will give a good peak concentration while reducing the residual concentration and thus reduce the nephrotoxicity. So this is somewhat different in our dialysis patients. In most medications, we give it post-dialysis. But this is one drug which we can give at a higher dose just before dialysis, ensure a good peak concentration, and then dialyze it in order to reduce the residual concentrations. And also we can use slightly less nephrotoxic agents. Tobramycin would rank lower than gentamicin in terms of nephrotoxicity. And so this would be one alternative in use of aminoglycosides. Coming to vancomycin, again there's a picture that is missing here, I'm sorry. So vancomycin is again a commonly used drug, and it's associated with nephrotoxicity when it reaches levels of more than 15 to 20 milligram per liter. So usually starts at around 4 to 8 days after therapy. How does vancomycin cause nephrotoxicity? It enters the cell through two ways. One is across the basolateral surface through this organic cation transporter, and across the luminal surface using megalin. So inside the cell, it goes and acts on the mitochondria, causing oxidative stress, and activates the caspase and the cytochrome enzymes and causes cell apoptosis. So another mechanism of vancomycin is that vancomycin inside the tubule will aggregate along with TAM protein to produce non-crystalline casts, vancomycin casts, which can produce tubular obstruction. So this is another mechanism. And in most cases, drug withdrawal will improve the kidney function in vancomycin toxicity. One interesting question that I wanted to answer from this talk was this question: does vancomycin and a piptaz combination cause AK? Because this is something that has been found in many trials, that this combination is associated with higher risks of AKI compared to other combinations with vancomycin. So they did a prospective cohort study where they compared a vancomycin piperacillin tazobactam combination versus vancomycin and cefepime.
What would we call, sir?
What is was 8% higher in the vancomycin piperacillin tazobactam group. But other biomarkers remained unchanged, like blood urea nitrogen, cystatin C. They remained unchanged. There was no differences in the rates of dialysis and death. So it was thought that it increases the risk of creatinine-defined AKI, but there was no difference in the other kidney function biomarkers, and there was also no difference in the downstream effects of AKI. So could it be possibly a pseudotoxicity, pseudo AKI in this? So the mechanism for that lies in the transporters inside the kidney. So if you can see here, creatinine and tazobactam both use organic anion transporter pumps to get secreted across the proximal tubular cells. So tazobactam can compete with creatinine for this secretion. Vancomycin, what it does is it adds to this problem by decreasing the expression of these organic anion transporters. So all of these will result in an increase in the creatinine level. So we might see a bump in creatinine when we combine this combination of vancomycin and piperacillin tazobactam, and this should be kept in mind. Coming to the next, now an increasingly used drug, which is colistin. As more and more of our bugs are becoming multi-drug resistant, we are left with colistin is the only drug left in our armamentarium. And we should know that the nephrotoxicity is dose dependent and it is not always reversible. So this is one study which compared colistin with a lot of other gram-negative antibiotics. And they found that at 72 hours, the rates of colistin-induced nephrotoxicity was about 20% compared to 11% in the comparator group. And at the end of follow-up, it was nearly 50% in the colistin arm compared to about 20% in the other arm. So a significant proportion of colistin exposed patients do develop nephrotoxicity. Why does this happen with colistin? Because colistin comes in the form of colistin sodium, which is a prodrug. And much of this colistin gets reabsorbed across the kidneys. All the CMS gets secreted. This colistin, it gets, even though it's filtered, most of it is reabsorbed in the proximal tubules. It gets reabsorbed again by this megalin pathway and the peptide transporter pathway. And inside the cell, it causes mitochondrial dysfunction and activates this death receptor and the caspase pathways, and all of these will result in necrosis and apoptosis of these cells. So how do we overcome this? We have to stop the drug. We have to adjust the drug dosing according to the GFR. We can use slightly less nephrotoxic alternatives. One option would be to give polymyxin. Polymyxin also can cause nephrotoxicity, but is associated with slightly lower rates, probably because of the pharmacokinetics. So colistin has a more flat curve, pharmacokinetic curve, so more prolonged exposure, whereas polymyxin has a peak to trough range. So it produces less residual levels and thereby less nephrotoxicity. Next, another drug which is tenofovir, which is now the very commonly used drug as part of our treatment for both hepatitis B and HIV. So we know that it exists in two forms. One is the two prodrug forms. One is the tenofovir disoproxil fumarate and the other is tenofovir alafenamide. The tenofovir nephrotoxicity can occur in about 12 to 24% of those exposed to tenofovir. And when was it first recognized? It was not recognized because of AK. It was first recognized when it produced osteomalacia in such patients. And when they recognized that it can cause a type of Fanconi-like syndrome. And that was when the tenofovir nephrotoxicity was first recognized. So this is a very fascinating picture. If we see that, we can see the interaction of several different things here. So tenofovir as such, its mechanism of action is to inhibit the RNA-dependent DNA polymerase in the viruses. But what it does, it can also inhibit the mitochondrial DNA polymerase, reduce the expression of mitochondrial DNA, cause mitochondrial dysfunction, and can damage the cell. So how does it enter the proximal tubular cell? From the blood, it enters into the cell through the organic anion transporters. It exits the cell through the multi-drug resistance protein gene on the luminal surface of these cells. So if we block the entry of this tenofovir into the cell, like if we give probenecid, it should reduce the nephrotoxicity. So this makes sense theoretically, but as far as clinical studies have shown, clinical studies go, it hasn't really shown a benefit in probenecid in preventing tenofovir nephrotoxicity. We can see that this ritonavir, lopinavir, this NSAID acyclovir and ganciclovir can inhibit this MRP, and so it will prevent the movement of tenofovir into the lumen. So it can cause accumulation of tenofovir inside the cells and actually increase the toxicity. So we should always be careful when we are combining tenofovir with these protease inhibitors like ritonavir boosted protease inhibitor regimens. So it will increase the risk of toxicity. Similarly, when we combine it with didanosine, didanosine is also an inhibitor of this polymerase, DNA polymerase. So it will also add to the nephrotoxicity. So how, one way of overcoming this nephrotoxicity is to give tenofovir alafenamide. So why is that less nephrotoxic than this TDF, the disoproxil fumarate? TDF is a very, it has low plasma stability. It's basically a tenofovir prodrug. Tenofovir is given as a prodrug so that it can be absorbed across the GI tract. But TDF will dissociate into tenofovir in the plasma more than the tenofovir alafenamide. Alafenamide will enter into the lymphocytes and then get transformed into tenofovir. So it has more plasma stability, so less tenofovir is available for entry into the tubular cell. So that is why tenofovir alafenamide is less nephrotoxic than the TDF version of tenofovir. So this is a classic histopathological slide. So the upper two slides is HNE and this is a PAS, which shows the features of acute tubular injury. Here there is tubular dilatation, tubular atrophy and interstitial fibrosis. This shows the mitochondria. This is in a HNE stain. It shows the pink eosinophilic mitochondria inside the proximal tubules, which then stains red or fusionophilic on the Mason's trichrome stain. This is a classic picture of a tenofovir nephrotoxicity. And if we take the EM, this will show the dilated mitochondria inside the proximal tubular cells. These are this mitochondria. So how do we prevent it? So we should screen all patients with HIV who are started on tenofovir, HIV or HPV who are started on tenofovir before their renal function and the proteinuria before starting it. And the IDSA recommends that anyone on tenofovir should have a biannual monitoring of creatinine, phosphate, proteinuria and the glycosuria, especially if they have a GFR of less than 90, if they are on other nephrotoxic drugs, or if they have a protease inhibitor regimen, or if they have renal risk like diabetes and hypertension. The IDSA also suggests that it should be discontinued if there is a more than 25% decline in the GFR and if the GFR is less than 60, especially if there are features of proximal tubular dysfunction in the form of glycosuria, phosphaturia, hypophosphatemia. So in that case, it should be discontinued. How do we manage? The management is only early drug discontinuation, but 50% can completely recover renal function over weeks to months, while some can progress to have a kind of subacute nephrotoxicity with prolonged CKD. Then another chemotherapeutic agent, this is the cisplatin nephrotoxicity. So cisplatin is produces a dose-dependent complication, usually at 5 to 7 days after therapy. It's a very common drug which can cause nephrotoxicity. It's one of the common reasons for call over from our oncology friends that the creatinine goes up about a week after starting cisplatin. So How does it enter into the cell? Again, this is the opposite of tenofovir, that is OAT, that is organic anion transporter. This comes in through the OCT, the organic cation transporter. Again, comes out through the MRP. So this also can produce a Fanconi-like syndrome. It's important to also look at the magnesium levels in these patients because it can produce magnesium wasting, can produce salt wasting. Yes, ma'am, potassium also. So how do we manage this? When giving the cisplatin, it has to be dose adjusted for the GFR. We can give IV isotonic crystalloid diuresis, that is the backbone of therapy. We can give lower dose regimens, and especially when the next cycle is coming, the patient can be prescribed slightly lower doses of cisplat, can be reduced by 25 to 50% during the next cycle of chemotherapy. We can give cisplatin analogs like carboplatin and oxaliplatin, which have a lower risk of nephrotoxicity. And in high-risk patients, sodium thiosulfate may be given. Mostly AKI resolves in few weeks, but some patients can develop progressive CKD with tubular interstitial fibrosis. When talking about drug-induced AKI, it's always important to remember that the kidney never forgets. So if it produces AKI once, some of these patients can actually progress to develop CKD. Now coming to the other phenotype of kidney disease, that is the drug-induced acute interstitial nephritis. So most of the drug-induced acute interstitial nephritis in high-income countries are due to drugs, whereas in India it's still mostly infections. Now slowly the epidemiology is changing towards drug-induced AINs. Nearly 50% are due to antibiotics, around 10 to 15% are due to NSAIDs. So when we, okay, again this picture is missing. This picture is missing, but basically the pathogenesis of drug-induced AIN is that the drug can act like a hapten. It can act like a planted antigen, can go and deposit on the tubular basement membrane or on the GBM, and it can act like a antigen, planted antigen. It can mimic certain antigens, and which in turn will trigger an inflammatory response. And it can cause it's predominantly a T cell mediated inflammatory response, which causes acute interstitial nephritis. So the dendritic cells will recognize the antigen, it goes to the local lymph node, it goes and triggers all these cells like the T cells, the mast cells, the leukocytes, the macrophages, all of these which enter into the kidney and produce an acute interstitial nephritis. So when we look at the number of drugs which produce, again this picture is missing, sorry. Okay, when we, there was a picture which has a list of drugs which cause acute interstitial nephritis. I think it's enough to know that almost every class of drugs can produce acute interstitial nephritis, from NSAIDs to proton pump inhibitors, to the antibiotics. Almost every class of antibiotics, from beta-lactam antibiotics to the sulfur drugs, all of these can cause AIN. But in spite of so many medications causing AIN is relatively uncommon. If we consider the amount of drugs we give, AIN should be occurring much more frequently, but it doesn't. So there's probably a lot of patient-related risk factors which are also in play here. They found that there are certain variations in HLA which can trigger this drug-induced AIN, and patients with certain specific HLA variants had higher risk of drug-induced AIN, also had higher severity of AIN, more severe tubular interstitial infiltrates compared to other types of HLA variants. So more study into this may help us identify the patients who would be at high risk of AIN in the future. How do we diagnose drug-induced AIN? The diagnosis would require a renal biopsy which shows the interstitial infiltrate after exposure to the medicine. But in many cases it is a challenge. We may not be able to biopsy the patient. Allergic features are rare in many cases. Some cases like NSAIDs and PPIs, they may have a long latent period between the drug exposure and the development of AIN. So what we need would be some novel urinary biomarkers like IL-9 and TNF-alpha, which may help us to diagnose this drug-induced AIN in the earlier stages of the disease. How do we treat it? The first step, as I already told you, this is a type B type of reaction, adverse drug reaction. So it has to be discontinued. The offending drug has to be discontinued. There is a role for steroids because we know that the disease has an immunological nature, so there may be a role. And but the disadvantage is that much of the data for role of steroids in AN comes from observational studies. Most studies have recommended a dose of recommended steroids for a period of 4 to 6 weeks within a month after the diagnosis. And if there is a no response to the therapy, we need to do a rapid taper. So this is one of the largest studies from the glomerular disease consortium in Spain, where they studied 182 cases of biopsy-proven drug-induced AIN. They found giving high-dose corticosteroids for about 2 weeks or giving a long duration of corticosteroids for more than 8 weeks at a moderate dose doesn't really improve the renal recovery. But they did find that giving late start of steroids was associated with lower chances of renal recovery. So maybe there is still a role for steroids. So it is important to identify who would benefit from steroids in drug-induced AIN. Those with greater interstitial infiltrate and less fibrosis, those with a higher GFR before the biopsy, and if we have this IL-9 levels in the urine available for testing, then those with these higher levels can benefit from steroids. At the same time, it's important to know the risk benefit and consider the risks of steroid toxicity in every individual patient. Also, as I said, the kidney never forgets. AIN can progress to CKD as high as 50%, especially in those with greater interstitial fibrosis. So AIN is one part of the drug-induced nephrotoxicity which needs a lot more research. We need some multi-center RCTs to study the effect, the duration and the dose of steroids. And we need certain targeted therapies. For example, targeted therapies against the mast cells may be helpful in AIN. So now coming to a very exciting topic in drug-induced kidney diseases, which is on the mouth of almost every nephrologist worldwide, the immune checkpoint inhibitor. So we talk about tolerance in transplant. The immune checkpoint inhibitors are the exact opposite of tolerance. So we know that this signal one is the interaction between the MHC and the TCR. And we need a positive co-stimulatory signal, which is the interaction between CD80 and CD28 on the T cell. This is between the dendritic, between the antigen presenting cell and the T cell. But there are certain other signals like the interaction between CTLA4 and CD20 and between the programmed death receptor and the programmed death ligand 1, which actually produce negative co-stimulatory signals. So they actually suppress the T cell activation, and they so tumor cells use these receptors to suppress the T cell recognition of the tumor cells, enable the tumor cells to develop to escape the T cell regulatory mechanism. So they make the T cells develop something like a tolerance against the tumor cells. So these tumor cells are not killed by the T cells. So what the checkpoint inhibitors do is that they overcome this checkpoint. These are the checkpoints, that is the CTLA and the PD are checkpoints. So the checkpoint inhibitors will block this negative co-stimulatory signals and allow the T cells to recognize these tumor cells. So these are the drugs which are commonly used, like nivolumab, pembrolizumab, and ipilimumab, and atezolizumab. So this is a very cute drawing of a cartoon of how the immune checkpoint inhibitors actually act. So the T cell tries to recognize the tumor cell here, but the tumor cell puts the T cell to sleep by using the PD1 and the PDL1 pathway. So what the PD checkpoint inhibitors do is that they block either the PD1 or they block the PDL1 on the tumor cells, and they prevent the tumor cells from recognizing creating a tolerance from the T cells. So the T cells are still able to recognize the tumor cells, and the tumor cell is able to kill the T cell is able to kill the tumor cells. But what is the disadvantage of this? So there is if we break this checkpoint, we also break self-tolerance mechanisms. The most important part of this PD-L1 and the CTLA4 is that it enables the self-tolerance and prevents the recognition of self-antigens by the T cells. But when we break this immune checkpoints, we actually are breaking the self-tolerance mechanism, and we can trigger an autoimmune response against antigens, against our own antigens. If these antigens are on the tubular cells, then this will trigger an acute tubular interstitial nephritis inside the kidney. And this occurs with an incidence of about 2 to 5% in patients who are exposed to these immune checkpoint inhibitors. This can the further increased this incidence of this immune checkpoint inhibitor AKI is further increased when the T cell is already primed against the self antigens by exposure to a previous nephrotoxic drug like PPI. If the patient has been taking proton pump inhibitors, it was found that the risks of AKI were actually higher with checkpoint inhibitors. So this was the largest study in the immune checkpoint inhibitor associated AKI. Near more than 850 patients were divided into those who had AKI and those who did not have AKI. And they found that the AKI occurred at a median of 16 weeks after starting the ICPI. And almost 80% of the, more than 80% had an acute interstitial nephritis. And the risk factors they found were PPI use, which as I already told, presence of extrarenal immune-related adverse effects. So if it can produce autoimmunity in the kidney, it can produce other autoimmune reactions elsewhere in the body, mostly in the skin, gut, and in the endocrine system. So it can produce a rash, colitis, thyroiditis. So if these are present, the patient would be at higher risk of nephrotoxicity as well. The good news is that most of these patients did respond to steroids. More than two-thirds will respond to steroids. And early initiation actually increased the recovery of after ICPI AKI. And less than 1 in 5 developed ICPI AKI when they were re-challenged with these immune checkpoint inhibitors after an episode of AKI. So it's important to know this because it is now going to become it's now becoming the backbone of cancer chemotherapy for several different types of cancer like melanoma, non-small cell carcinoma, non-small cell lung cancers, and even the renal cell carcinoma and so on. So it's going to be increasingly used, and we are going to see more and more of these as we go on. It re-challenge does cause me, but it is less than 1 in 5. So say that the rates of re-challenge are about 16% that have developed earlier. When it is restarted, about 16% develop. Yes, still a good number, but if it is, but. So then coming to the last of these, the crystalline nephropathies of the AKIs. I am not going to go very deep into crystalline nephropathies. Almost everyone knows about it. So we know that any drug which is excreted via the kidney, any drug at a higher dose, patients with underlying renal disease would be at risk of crystal deposition. And certain factors like urinary pH are very characteristic in this. Like methotrexate and sulfasidazine would get crystallized in acidic pH, whereas indinavir, atazanavir, and ciprofloxacin would get precipitated in an alkaline pH. So we need to change the urine pH to the opposite direction if we want to reduce the crystal formation. So this would be the pathogenesis. So we think that the crystal formation and the tubular obstruction would be the cause for the AKI, but this actually contributes less to the AKI than the cytotoxic effect of the crystals. The most important pathogenic property of the crystal is that it enters into the cells, causes necrosis of the cells, and it can also trigger an inflammation through the dendritic cells and other parts. This is the most important cause for the AKI with crystal. So one of the very common drugs, again from our oncology friends, is methotrexate induced nephrotoxicity. This usually comes when the daily dose of more than 500 milligram per meter square is rarely used in rheumatological cases. So it is mostly from the oncology department that we will see these kind of cases. When the values are more than 10 micromole per liter, patients are at high risk for toxicity. Usually occurs in about 2 to 12% of patients. So this is a characteristic methotrexate crystal. Usually it can produce needle-like crystals, but sometimes they can form annular shapes, and they will stain positive on silver stain, and they are birefringent on polarized light. Treatment, as everyone knows, would be hydration, urine alkalization. We can use leucovorin according to the which the dosing would be according to the plasma methotrexate concentration, and it's important to promptly recognize it and manage it. The one new factor in methotrexate toxicity would be this glucarpidase. So glucarpidase is actually an enzyme, bacterial enzyme, which will cleave the methotrexate. And it's the only drug which is known to reduce the intracellular concentration of methotrexate. So we can do dialysis. Dialysis will reduce the plasma concentration, but it will cause there is an immediate rebound. It does not reduce the intracellular methotrexate concentration, but glucarpidase can actually reduce the intracellular concentration. But the main drawback is the cost. I searched online. I saw that it was costing around $27,000 for 1 vial of 1,000 units of glucarpidase, and so I don't know how much it can be used at present, but maybe down the line it might become cheaper and we might be able to use it. Then sulfadiazine and sulfamethoxazine. Almost every MCQ person every person preparing for MCQ would have seen this sheaf of wheat birefringent crystals with sulfur drugs. It's important to know that this can produce interstitial fibrosis with inflammation, even in the absence of crystals within the tubules. Most of these sheaths of wheat crystals are seen in urine. Biopsy, we may not actually see the crystals. Indinavir, characteristic features of these indinavir crystals is that they produce needle-shaped crystals and they produce a giant cell reaction within these crystals. So it is like how we see in cast nephropathy. It produces this giant cell reaction, which is a very characteristic feature of indinavir crystalluria. Other crystalline nephropathies, one is triamterene. You can see the yellowish brown crystals. Again, I think the ciprofloxacin one has been lost. Then coming to glomerular diseases, I really don't want to go into the glomerular diseases due to drug induced, because there is a whole host of diseases which are caused by drugs here. And almost all of us have read about it. But I want to answer a couple of important questions that we are often asked as nephrologists. So we get patients referred to us by our ophthalm friends. Like, if we give intravitreal anti-VEGF agents, would it cause any renal risk? Is there a renal risk? So there are case reports of glomerular diseases, worsening renal function, hypertension, and proteinuria, even with intravitreal injection of these anti-VEGF agents like bevacizumab and so on. Especially when the patients are given multiple injections, there can be significant systemic levels of these drugs, even which can near the IC50 of these drugs. This will depend upon patient factors like their retinal vascular permeability, depending upon their baseline VEGF activity, and certain genetic factors within the patient which will modulate their VEGF levels. So how do we manage these? What do we tell our ophthalmologists? So it's important here to document the dose and timing of the medications, and we have to rule out other causes of the kidney disease. If there is a rise in creatinine of more than 25%, or a rise in blood pressure of more than 20%, or if there is a proteinuria rise of more than 25%, look again for other reversible causes. We need to see if there are we need to reduce the dose or reduce the frequency of the drug, or we can switch to alternate agents which have less systemic absorption, like ranibizumab is said to have less systemic absorption. The other glomerular manifestation, the dreaded manifestation of anti-VEGF inhibitors would be the glomerular pathologies like thrombotic microangiopathy, in which case we would tell them to stop the drugs. So coming to the chronic kidney disease part of drug-induced DIKD, as I told you already, there is not much data on this. We do know that prescription and over-the-counter medications like NSAIDs, lithium, CNIs, and PPIs can cause it. Herbal medications, classically the aristolochic acid nephropathy. Then herbal medicines like which are contaminated with heavy metals like lead, cadmium, arsenic, gold, all of these can also produce chronic nephrotoxicity. Certain illicit drugs like cannabinoids, heroin, and cocaine can also cause chronic kidney disease. Again, I want to answer a couple of questions in this segment. Do PPIs cause CKD? Several studies have shown that there is an increased incidence of CKD with long-term PPI use. They have found that there is a higher the dose and higher the duration, there is an increase in the risk. Whether this is due to PPI-induced acute tubular interstitial nephritis which has progressed to CKD, or certain other unknown factors like endothelial senescence which has caused the CKD is not clearly known. So most of this data comes from large population-based studies. But it's more than several years of PPI.
More than 4 weeks, I think it's not more than 4 weeks. If it's indicated only, you continue.
Yes, sir. So that is why this is something that is still under debate, because although those population studies showed a higher risk, this is a recent RCT. Actually, this is a 3/2 RCT where on one side they compared pantoprazole versus placebo, on another side they used it for cardiac comparison of rivaroxaban and aspirin. So here they found at a follow-up of 3 years there was no difference in the chronic kidney disease between the pantoprazole group and the placebo group. But the limitation is that they say that 3 years may not be sufficient to see this effect. So again, loss of this play. So there is a deep prescribing protocol. Whether PPIs cause CKD or not, it is important to know that they may be associated with CKD on long-term use. And it's important to always review the need for PPI in every individual patient coming to our OPD. So I know this is the most difficult part of telling a patient.
Very difficult to convince.
So what else can we give?
The alternative is to use H2 blockers. That is also now getting
Is the
problematic.
shortest duration possible?
Shortest duration possible.
And intermittent dose.
Prescription continues. When
Yes.
people get so much used to it, the minute we tell them, they're so reluctant to take.
Placebo effect, yes. So it's always important to keep a de-prescribing protocol in place in every center, and that every time a patient on PPI comes back to us, we should see whether it is
How long it
really
is
required or not, and stop it when it is no longer required. As much as it's possible to convince our patients. And now we come to a full circle. We've come back to analgesic nephropathy. We started with analgesic nephropathy. We come back to it. Does it really exist? We did say about the phenacetine kidney. The NKF does describe the analgesic nephropathy as a disease that comes from habitual consumption of a mixture of at least 2 analgesics over a period of several years with papillary necrosis and chronic interstitial nephritis. So we require analgesic abuse which is defined as a consumption of more than 3,000 tablets over a 5-year period. But now that phenacetine has been removed, the incidence has markedly declined. Also, before, the analgesics used to be combined with an addictive component, which was codeine. So that again has been removed from these combinations. So it is declining. But even now, we do see some patients who have taken a cumulative dose of more than 2,000 grams of analgesics over their lifetime are at a risk of analgesic nephropathy. But we still haven't been able to establish a causal relationship between analgesic nephropathy and paracetamol. Again, as for PPIs, always important to keep a protocol to give it only when indicated, only in patients who are absolutely require these drugs. So I'll finish off my topic with the R's. I'm sure all of you would have seen RRR, but it's important to know the 6 R's here. So risk, first R for risk. It's important to know the risk of nephrotoxicity for each patient, for each drug. And it's important to recognize it as early as possible, respond appropriately either by stopping the drug, reducing the dose, give renal support through hemodialysis or anything else as required. Rehabilitation of the patient in the form of follow-up of these patients over a long term to look at the long-term effects of these drugs. And of course, further research is required, especially need to identify some newer biomarkers which will help us to identify this DIKD earlier. Thank you.
I would like to say a few words from my experience. Actually, in 1998, I have seen a patient, actually is the owner of GRT, Mahalakshmi Amma. After bilateral hypertrophy done at States, she came down to India. Following that, she had a severe pain. What happened? I consulted a doctor, they were given a Brufen. Then a patient had gone for a renal failure. Actually, I have given one dialysis, proton dialysis patient become moderate. Since then, till the end of her life, I was looking after the patient, thinking that something wonder. Actually, Prabha also helped during that time because I was about to go to Lucknow for this conference we had, pediatric conference. That time I went there. Then another thing in case in 77, end of 72, beginning of 90, in pediatric, what happened, whatever infection, diarrhea or pneumonitis, they give aminoglycoside. They used to give because they won't recognize it is because children will have a polyuria. They won't do this creatinine those days. So we failed to diagnose renal failure in spite of having it in this process. Then it's slowly. In case of amphotericin, we come across, though it is the drug of choice in case of fungal infection, whether it is a PD or a transplant cases. Liposomal amphotericin will help to avoid the complications. Then ciprofloxacin is having this crystalluria. Without knowing, in case of enteric fever, whenever there is or the mixed infection, they give this ciprofloxacin. Finally, one day they'll come on tubular. Case of crystalluria. I want to say.
You have almost covered everything. Touched on the anesthetic drugs. How does this propofol as AKI came out in the papers? Any idea? How many cases of it? Ayurvedic drugs. How many are there? At least we should make it a point from this side to analyze what are the herbal quantities. Those days when I was working, I used to send the drug to IDPL. So IDPL will actually analyze the contents of the drugs and then let us know. Many of the times, to our surprise, it was steroids. Heavy metals, steroids. IDPL was doing it very regularly. We had to find such a place where they do it properly and then secure the drug and try to do it and then tell the patient. If you just generally tell a patient, they are saying the government is organizing Ayurvedic college, they are very much in turn to go in for mixopathy. Stop those drugs. It's so harmful. Why do you encourage? The government encourage? People ask you questions back again. You should have definitely an evidence proof just to tell them that this is not the right way. Then they do everything and they send it across to us, and then we are not able to answer all those things. You should find a place where you can actually analyze. I don't know much because that was the time when I was a first MBBS graduate. Likewise, the health trainers, they ask these
Supplements.
creatinine. So I have a 19-year-old boy and a creatinine of 13, but he was looking well. No hypertension. Because the creatinine was high, we had to admit. Evaluated everything. Everything was normal. So because he was in the hospital, he didn't get the creatinine. Slowly it came down. So this is for the muscle building. So not only that, they asked all those gym trainers asked them to take calcium, IV, many fellows with vitamin D, vitamin D injections are injections are given by optometry and mainly by the gym trainers. Nephritis and diabetes. So that aspect also we should explain.
Yes. There's also the new drug, SGLT2.
SGLT2.
Yes. Say no. No harm.
Nice talk, Sangeeta. Excellent speech. Can you hear me?
Ma'am,
Not able to hear well.
Muthu ma'am,
Can you hear me? Can you hear me? No.
Ma'am, will connect on the phone now.
Actually, we
Not
are
able
using
to
this
hear, no?
steroid right and left in case of a minimal change in nephrotic syndrome.
Not unmute.
Back I was seeing a case of a 14 years boy.
I will
Can you hear me now?
Syndrome since
No?
third year onwards. Now and then he used to have a.
Sangeeta, can you hear me now?
ma'am, just a moment, ma'am. I'll just connect on the phone now.
Completely.
Okay.
This is a non-nephrotic range of proteinuria. Biopsy found to be minimal change in nephrotic syndrome. Because he had so many from 3 years onwards to 14 years till the just 6 months prior to that he was on steroid. Then I have seen during my service I have seen liver muscle is doing good and that otherwise he doesn't look like a nephrotic syndrome. Very thin individual, 14 years, very happily going. Started liver muscle, I sent the patient yesterday.
Put your comments.
Can I talk? Can I say?
Yes, ma'am. Yes, ma'am. Go ahead, ma'am. Go
You
ahead.
can hear now?
Muthu.
Okay.
Yeah, Muthu ma'am here as a moderator. Yeah.
Sandhya, it was an
Go ahead,
excellent
ma'am.
talk by you. We learned a lot. Can you hear me?
Yes, ma'am. Thank you, ma'am. Yes, ma'am.
Excellent talk, and it was very nicely done. We learned a lot from your talk. I just wanted to know one thing. You said amikacin you give before the dialysis. Usually we practice after the dialysis.
Yes,
Uh,
ma'am.
at the end of the dialysis, the dosage is given. Reduced dosage on alternate days or once in 3 days, like that. But
Yes,
you
ma'am.
said to give it before the dialysis. Isn't it
Yes, ma'am.
dialysable, the drug?
Yes, ma'am. Actually, that is why they making use of the pharmacokinetics of the drug, ma'am.
Uh,
To give a higher dose, we give the full 15 milligram.
Can't hear now. Not able to hear you, ma.
Can you hear me, ma'am?
Now okay. Tell me.
So what it does is that if we give a higher dose of 15 milligram per kg about an hour prior to dialysis, we
Mm.
get a good peak concentration, ma'am.
But
But
is it not dialysable?
yes, ma'am, and then it will get dialyzed, so it will reduce the residual concentration, ma'am. So it's a concentration dependent killing. So what is important is the concentration above the MIC.
Oh, so I thought usually our practice used to be like that at the end of dialysis.
Yes, ma'am. Yes, ma'am. So this is they are making use of the pharmacokinetics to give a dosing like this, ma'am.
Excellent talk, Anita.
Thank you.
Congratulations for
Thank you.
giving this great talk. Thank you.
Thank you. Thank you, ma'am.
Thank you all.
Thank you. Yes, ma'am. Yes, ma'am. As it is available, I think if we push for it, it's most of the time it responds on its own, ma'am. So we have not really used it. Yes, ma'am.
One company that came with oral formulation.
Yes, ma'am.
They write beautiful ASEAN tablets. IV is
I have never used it, ma'am, actually, so I don't have any experience with it.
because I have given.
It should be given for calcifilaxis.
Yes, ma'am.
Calcifilaxis is IV. Here also is IV or oral?
Here this IV.
I have not.
Even but most of the time with our cisplatin nephrotoxicity, it usually responds when we just stop it.
And many of our neurology colleagues use lot of IVIG.
IVIG. The osmotic nephrosis. I did not touch upon it. Yes. We've actually seen one in a patient of post-transplant. We had a ABMR where we tried a high dose, not an ABMR, sorry. This was a patient with who was a sensitized patient where we tried a high dose IVIG regimen. Continued the IVIG post-transplant, gave it for 3 days prior and then 2 days after. After transplant, the patient actually had an AKI and the biopsy actually showed features of osmotic nephrosis. Initially, I thought it was an ABMR because it was a sensitized patient. Turned out to be it was osmotic nephrosis because of the IVIG we gave.
Lots of anesthetists also use this hydroxy
Starch, HAL.
Yes, true.
Colloids.
They are very popular with the hydroxy.
Nowadays it has come down, ma'am. After the
Now it has
hypothermic,
little come down.
it has come down.
IL-9, ma'am. It's right now it's all under study. IL-9 is a marker for mast cells, so that may be a specific marker for AIN. All under I think under research.
Eosinophiluria and all is not too commonly seen. Probably eosinophilia is there, but eosinophiluria and all is difficult to pick up.
IVIG. High dose means we're giving 2 grams per kg, so comes to around 100 grams. So 100 grams.
5 gram, 5 gram per kg.
2 grams comes to around
A lot of
per kg.
AB incompatible also you can.
We gave it over a period of 5 days. We gave 20 grams per day for 5 days. 20 grams per day for 5 days. Yes.
Sometimes alternate days will also
We
be
didn't
considered.
do plasmapheresis for that.
Suppose it's not working, immediately jump
Ah,
on the
5 gram per kg.
So I just thought once I have to biopsy. Typical osmotic.
I think this has come up well.
Yes, ma'am. Some modifications this we have taken from the WIN.
Do you want to address address?
But here, any other comments? I think we can probably still the session is on. Okay. Madam, closing remarks for the scientific session or something else you want to say? Probably we can ask some more questions or something. Any more questions from the
I
virtual
think we have to ask. There's anyone in the chat?
chat box or something?
Message.
Hey, ma'am, have to leave. Madam, you have to be there. Okay. Madam have to be there. Okay.
No, they can hear us. We are not able to
Madam, you'll just call her. Huh? Sarojini, can you call Madam to just at least for another 15-20 minutes so that we can finish up a main discussion? Yeah, plus also this whatever we have prepared, it will be shown actually so that for others to see. So, okay, we should.
Thank you, Sandhya, for the wonderful talk.
Yes.
It's quite a tough one.
Very nice
Short
presentation.
presentation.
Thank you.
Prepared very well.
SGLT2 also could have been added, but it's like
did
few
not
things
add
that and sacubitril valsartan.
Touched upon
Commonly.
hemodynamic.
So you close the session.
Close the session. Okay. No one is putting any pictures.
Inhibitors that are safe.
That ranibizumab. Yes, ranibizumab.
But still, ma'am, that also is associated with.
It also has.
It also has got as effect, but still initially, the sooner you give the early stages of CKD, we normally approve. Probably CKD stage 3B, 4 and all maybe little more risky, but because progression of diabetic retinopathy occurs during dialysis also, it is good to treat rather than not to treat. So with eye problems. So,
True. Yes.
But people come with this stuttering progression, and if you ask, they will tell you steroid injection. Okay.
or like better to go for then if not able to give injection, you can go for laser therapy, and that is much more safer.
See, they have to tell how much difference it makes compared to laser, but nobody comes up with any of that data, right? Now,
Probably
everybody goes. They recommend intravitreal injections for almost
everybody. But then now clearance is being obtained all the time. They normally send it to Shankar and on and off. They send it to us for clearance. Without that, they don't proceed for intravitreal injections.
But many patients come after.
Then probably yes, we should alarm them.
They have to show some light as to how it compares with laser, how much superior it is, particularly in CKD patients. They are the ones who can comment on that.
Probably we can have after.
We can have ophthalmologist come and have talk and then discuss and then.
Actually, I mean, many patients do well actually, according to them. And whoever gets into trouble, and we do not know whether that's the cause because the disease is already progressing. We don't know whether that is the cause.
You can have the mic.
CKD group is always. The CKD group already has a lot of issues.
Change the recording. Shall I disconnect it?
It shows like that only they know.
Other people also should see.
Or you can put it here.
You can put it here.
Yes, so
Hopefully they don't.
where is the
It's
slide?
there in the desktop.
Probably what we can do is.
Actually, pen drive you.
We can go out there. I mean,
Instead of process in the minimum and switch it off. Many things I have not even closed. This one.
that should be very important. Everyone is raising that. Slow down.
Everything is clear.
Yes. Just share it.
You can no, you can be there because if I read it from this, probably you can slow it or run it probably faster.
Not that, but commercial interest is there. Actually, we don't see any referrals. I mean, they say we only.
I think the topic was so interesting. I really enjoyed doing it because justice to the topic. So that okay, a lot of things we covered, so we did it really well. Interesting. Yes, we had a lot of graphs and cartoons. Difficult, but it's so easy to accumulate everything in a short period of time and do it really well done.
Excuse me, ma'am.
Hello?
Muthu ma'am has joined. Muthu ma'am has joined.
I joined, yeah. Give me, ma. I have another meeting to go home. So kindly.
Hi everyone.
So such a long. You're dressing me, but I have not met you before, sorry.
I think so.
Welcome. We had the first registrar as her resident who actually joined pre-COVID, the first time when we had the meeting. We
Can't hear you.
Oh,
Hello.
very nice.
So you have a bright future too.
Please talk on Zoom. Not able to hear you.
Yes. Ma'am, are you able to hear us now, ma'am?
Now slightly. Okay. Now okay.
After the scientific session, which was concluded well, we have a small discussion on the registration process of women in nephrology, Tamil Nadu and Puducherry wing. This is what we are going to name this as. So this is a letterhead which you all can see on your screen, which is we have the address as WYN and TN and Puducherry wing, and registration alone is pending. And we have the address courtesy Dr. Vinita. The address is Department of Nephrology, Vinita Hospital, number 70, Joshia Street, Tirumurti Nagar, Nungambakkam, Chennai, 34. Thankful to Vinita ma'am, thankful to Sarita madam who has shared the address for the Women in Nephrology, Tamil Nadu and Puducherry wing official address. And probably the correspondence and all still we'll just keep it in the mail. In case any physical correspondence, probably I'll interact with Dr. Sarita from time to time. So we have executive committee which consists of patrons. We have Dr. Puducherry ma'am, the pioneer in the field from Chennai. We are very proud to have you, ma'am. You should continue to be with us and continue to guide us. We are still amateurs and we have a long way to go ahead. So under your guidance, I think we should be able to walk our way through. And also I welcome Dr. Tamilasi ma'am from CMC Vellore. She is retired from there and at present a part of Narayani Hospital at Vellore. I'm so happy that we have two senior most people who are still young, energetic, continue to practice, and are almost jubilant and mostly attend to most of the online lectures still, and continue to guide and learn. So thank you, ma'am, for being there as patrons. We didn't have any inaugural meeting of WIN, Tamil Nadu and Puducherry wing as other branches. Probably we'll look forward to have that in Yelcard meet as of our first annual meeting if time permits. I'll just probably do a small inaugural. Next we have President Dr. Prabha Sangudavan ma'am, pediatric nephrologist from our city since time memorial, I would say, and she retired from ICH, I suppose. And I didn't have to see you at Ham ma'am, but I think nice to have you because we have a combination of both adult and pediatric really parallel running hand in hand well. Then we have other junior colleagues who are participating quite well and putting programs from time to time. So thank you for being there, ma'am, and we are looking forward to your support and a lot of activities are at your guidance. We have next is Dr. Anita ma'am, Anita Jagannath. She's the Vice President. Thank you, ma'am, for accepting the post, which is, I think, very short notice. I had requested you, and thank you for accepting it. So it's good, ma'am. It's a blessing in disguise, I would say. Then Secretary myself, Ranjani. We have Joint Secretary Dr. Indumati ma'am, who is from SRMC, Senior Professor there, and probably looking forward to change your place of work. All the best wishes, ma'am, and also looking forward to your support from time to time, and constantly your support. You have to be there around. Next, in the scientific in charge, we have Dr. S. Jayalakshmi ma'am, the nephrologist in charge at Oman Hospital. She's quite dynamic, active, and almost has come forward. Any single first call, normally I make to madam only. And she literally takes it at whatever time, and even at late night calls also we have enjoyed. And thank you, ma'am, for being there and continue to support us. And she'll be coordinating with other two members for all the scientific proceedings, and although all the annual conference scientific discussion would be there in concurrence with her. Whoever is the organizing secretary will coordinate with her for the successful conduct of the scientific program. Then we have treasurer. Thank you, ma'am, Dr. Radha Venkatraman ma'am. This is one of the most difficult posts. Probably nobody will accept it so heartily and so easily. And so thank you, ma'am, for accepting it. I think all the nuances we'll take care also, ma'am. We'll face it together. So thank you for being there. And we have executive members. Mostly we've tried to incorporate everybody from all the cities or probably all the regions of Tamil Nadu. But I have taken Dr. Priyankada ma'am is there from JIPMER. Dr. Suganya is there from Mehta Hospital from Chennai because we need some local people also to coordinate. We have Dr. Dhanapriya. She's in KMC now and also attached to some private hospital outside. So she's also from Chennai. Dr. Yailasi madam, she is in Panimalar Medical College. And we have Dr. Abhinami from Salem, going to be the first secretary of the first annual conference at Yelcard. We have Dr. Nitya from Trichy, Madurai. We have taken two names out. Dr. Saxena madam didn't want to be part of the member there, so we have taken her name out. One more person is Dr. Aishwarya Annamalai from Trichy, I think. So we have one Lakune from Trichy. I think if somebody is there, that name. So probably we can have that. So probably so we have actually two things which are different from the WIN Central. It is they don't have a scientific in charge, which we have, and the other one is the WIN newsletter and the journal, where we have two dynamic ladies. This is Dr. Rajiv Rojna from Triple M Madras Medical Mission, and Dr. Kalaivani Ganeshan from Mehta Hospital. She is there here. So thanks to be part of the newsletter. So we have to really actively support her. with newsletter from time to time. E-journal should be there at least on a quarterly basis. Monthly, we should try to at least give at least one journal, or I think Aarti is also helping out in that, in putting some jokes or some puzzle. Okay, Neph Madness was a great success, so thanks to Sandhya around. So whatever possible, I think we should work out more to show our media presence, which is, I think, I feel is a little lacking. I think we have two competitors. We have one on the left side, one is from Karnataka. They are doing good. They have just recently had the inaugural function, so they are very strong in their media presence. So we request all of us to at least actively contribute and energetically work towards with their thoughts. At least seniors can also contribute through their thoughts. It can be converted into media object through the youngsters or any helpers. Sarojini can help out from time to time. She's almost there. I have snatched her from Novartis actually. So she's an active participant in WIN actually for us. So today also she has attended. She's attending the function not as a Novartis person but as a WIN person. And so that completes the executive committee. So I just want everybody to just check their names, initials, so that we can go forward with the registration. Yeah, but I think aligned, but I think it is there in that the letterhead is okay. Right. Muthu ma'am, can you hear me, ma'am? Thank you.
Rajiva ma'am has put a thumbs up.
Thumbs up. Sure. Huh? Madam is not audible.
Ma'am is on mute.
Ma'am is on
She
mute.
needs to unmute.
Thank you, Aarti, also for her active participation, because she's in charge for the tickets. Without her, we can't go. Thank you. So I think you're going to have the tickets.
Hard copies. Are you also sponsoring the tickets?
No, tickets are actually free. Actually. So yeah, okay. So it's free actually as of now. We've got through some people who have helped us to get the tickets and the travel from Salem to Yerkad also. So we'll just go on to the next one, which is the bylaws. So we have how many online people, because it's important to show it to them too.
We have only got 6 people. No, ma'am. Only 3 are online. Only 2, ma'am. Dr. Jyoti Priya and Dr.
These are all really common.
Correct, but 2-3 things actually I just thought, yeah.
Anything specific you want to highlight?
Yeah, I just probably rapidly run through probably. AIMS are name of society we already know, location we know. AIMS is just to non-profitable and non-commercial association. So to hold meeting, conferences and exhibition from time to time to organize medical camps whenever possible. The 7th is not applicable to us, it is from the central this thing, WIN. The 8th is not there, I'll just rearrange that. The 10th is, again, I've just told, e-newsletter, e-journal and e-library. We have to contribute to that, to cooperate with other associations. Okay. And the other two, the 11th, the 12th one and 13th one can be skipped because it is mainly for the Central India. Certified that no association is found with no profit motive and no commercial activity is working, and office bearers are not paid from the funds of association. So we are all working free. We are happy to work like that. Certified that association would not engage in any agitational activity to ventilate to grievances. Okay, and also the signature whichever will be there are genuine. Next page will be document 2. Members, actually we are all life members. So membership fee may be a simple payment, the quantum of which shall be laid down from time to time by the executive committee, again from the central. This is not from the RDN. Be admitted as life member. And annual subscription also should be paid to be continued as life member, the quantum of which should be laid down by the executive committee from the TI and central from time to time. Associate members who are not life members, they tend to become associate. Like they are not working in nephrology, or they are nephrology, internal medicine, pediatrics, technician and nephrology, nurses and administrator and transplant coordinators. There are no life membership or for association members. From time to time they may have to pay and renew their membership. So this is not applicable to us now. So all the members of WI and TN are life members as of now. Okay.
Postgraduates are also.
Are also, yes.
Maybe from different states.
Correct. But only thing is they are continuing as a consultant here probably will be life members. People who move
Maybe
out.
associate.
Associate members,
Postgraduate,
associate members,
once they become a consultant, they can
they become a life member.
life member of the
Particular state. Yeah.
associate is not required now, but is required because some of them have joined as an associate. Pathologists are all associate.
Login and password also, and then you can open it. Thank you. Thank you so much. Yeah, no problem. And we have cessation of membership anytime is possible, and notice to be given to secretary, and they can cease to be a member. 3.2, ma'am. Yeah. Next is privilege of membership. This is the important thing for all the activities the office there. All the life members and other members shall be entitled to participate in all the activities of the society, and life members should be entitled to vote for the election of office bearers. The affairs should be managed by executive committee. Composition, as actually we have already discussed this: president, vice president, secretary, joint secretary, treasurer, scientific in charge, Vince new writer and e-journal in charge, and executive member. So the post, okay. IT is being served, I think. Sorry, ma'am. Thank you, ma'am. Sarojini.
போரும் வேணா பாதி எடுத்துக்கிறேன் வேணா
Snacks are there. So why don't you tell them to have it actually? Take it and please accompany madam down and then.
Ranjani, can I talk to you? No? இங்கே
I don't think you.
Ranjini ma'am.
We can go through.
Ranjini ma'am.
It's a long day.
Sure. You just go through. Sure, ma'am. Fine. Sure, understand. Okay. So, but also the strength was quite less, ma'am. But also we want to discuss how.
Muthu ma'am, just give me 1 minute. I will convey your message right away.
Okay.
But I want a feedback a little early from all of you.
Only thing is what I feel. What to call other than nephrology,
Okay.
connected with us to speak sometime and not be a closed nephrology forum by itself, say ophthalmology.
Yeah, I think we have got a
Something like
guest lecture.
You got
Yeah.
Every third month we
We will have a guest
we
lecture.
have a guest lecture. Especially people who are very
pathologists,
pathologist and infectious person. You know what happens? Many times I feel the coordination is not little healthy in many places. We can try to cover all that, but then that's one thing. And then a lot of stress has been given towards transplant and what's happening. I'm very happy with it. At the same time, we should have our fundamental
Rajni ma'am, can you hear me?
for us to know the regular nephrology, general nephrology to be included much more.
Okay.
Okay, leave it, Ma. I'm leaving.
Ma'am, just 1 minute.
I think
She
I'm
will
not
connect.
able to
Just
hear
1
her.
minute. 1 minute.
I'm not able to hear. Actually, I'm just thinking somebody's talking, but I'm not able to hear, ma'am.
Yeah. Yeah.
Still speaking my phone.
Rajni ma'am, Muthu ma'am wants to talk to you. Yeah. Can you hear us?
Can you hear me?
No, I think.
Okay, Ma, I'll talk to you later. Yeah, another business I have to do.
Hello, Muthu ma'am.
Yeah.
Yes, ma'am. Sorry, we're not able to.
Okay, can you hear me now? Can you? Oh, I'll talk to you later.
can speak. Hello?
Can you hear?
Yes, ma'am, we can hear you, ma'am.
I just wanted to know why you have put so many patrons, all others in the group. Because
Yes, ma'am.
this is not one national meeting. This is the only Tamil Nadu meeting now, Win branch, you know. You put
Yes, ma'am.
why
Yes,
so
ma'am.
many patrons?
This is
Why?
our letterhead, madam. This is our letterhead.
But you put so many that the other one?
No, madam. Only one only had put it back. The
Plus
letterhead of
7 people are there. The people. Yeah. I can't hear you. Okay, I'll talk to you later, Anjani. I have another meeting. Patron, there are 7 people are there. Come down. No, up. Go up. But there is another letterhead. What is that? There's one here. What is that? What is this? 2 letterheads, huh? Okay, I can't hear you. I'll talk to you later. This one?
Vijay, you need to unmute on Zoom and you need to disconnect on mobile. Then ma'am will be able to hear you all.
Okay.
Leave it, ma. I'll talk to her later. Just leave it. I'll talk to her later. Okay? I have to go for another meeting, ma.
Okay, ma'am. I'll convey the message, ma'am. Okay.
Thank you. There is a webinar on aorta, the silent killer, by the nephrologist and Palak.
Okay. Okay, ma'am, we do understand.
I will call her later and talk to her. I don't know what it is. Okay?
Yeah.
Thank you.
திருப்பி வந்துட்டு இருக்காதேடா. Beta, you just bylaws போட்டேல, and bylaws வந்து இது போட்டிருக்கே பாரு நீ. சென்ட்ரலோட ஓகே அது வந்து கரெக்டா எனக்கு கிடைக்காம இருக்கும்போது தான் I just got it confused. So madam thought that we have 2 letterheads. So just tell her that, no, just call her up and just tell that on
Why we are having 2 letterheads?
we don't have மேடம் சொன்ன பேட்ரன்ல 7 பேர் இருக்காங்களே செகண்ட்ல அது பைலாஸ் மட்டும் தான் எடுத்துக்கீங்க மேடம் கண்டென்ட் லெட்டர் ஹெட் ஒன்னு தான் மட்டும் சொல்லிடுங்க சரி கண்டென்ட் டு டேக்
பர்சனலா போய் கொடுத்துட்டு வந்துடுறேன்.
அது ஓகே அவங்களுக்கு வந்து நீ ஃபார்வர்ட் கூட பண்ணலாம் ஐ வாண்ட் டு ஃபார்வர்ட் மை நெட் திஸ் ஒன்லி லெட்டர் ஹெட் சொல்லுங்க
மேடம் இது வேணா மேபி
பிகாஸ் எனக்கு லாஸ்ட் வீக்ல நீ கொடுக்கிறதுனால இல்ல அது கரெக்ட்டா சென்ட்ரல் தான் எடுத்தோம் நம்ம கரெக்ட் அது ஜஸ்ட் மேடம் கிட்ட சொல்லிடுங்க she just thought it to be இல்ல 2 இல்ல சொல்லிடு
Yes.
அப்ப நம்ம வந்து we should collect without knowledge of Muthu madam. ஆமா.
Yes, we will do that.
Now we are talking now. அப்படினா நம்ம என்ன பண்ணனும்னா we should just personal ஒருத்தரே கேட்டு we have to just collect. And then அதுக்கு என்ன வருதோ we will have a good
First you have to find out the cost of the name.
நம்மளோட குரூப்லயே போடலாம்ல so that everyone அந்த மாதிரி ஃபார்வர்ட் பண்ணி
பட் ஏன்னா அவங்க ஃபார்வர்ட் பண்ண உடனே டிஎன் விங்ல தான் போகணும்
நம்மளோட
இது வந்து மாடிஃபைட் கண்டென்ட்
whatever திரும்ப modify பண்ணனும் நம்ம
மாடிஃபை பண்ண ஜஸ்ட் இந்த 8 மட்டும் தான் 8 நம்பர் மட்டும் தான் கரெக்ட்டா அது மட்டும் பண்ணிட்டு அது ஜஸ்ட் not everybody has given any comments. It was I think difficult to coordinate. இங்க யாராவது இருக்கணும் probably.
Actually நம்ம என்ன ஆச்சுன்னா நமக்கு வந்து fourth year I was a volunteer for அதுதான் நினைக்கிறேன் நான்.
சரி மேடம் இது கண்டிப்பா இது வந்து மெசேஜா போடுங்க இது வந்து ஜஸ்ட் ஃபார்வர்ட் பண்ணிடுங்க லேட்டஸ்ட்
சரி முடிச்சிட்ட அப்புறம் நான் உங்களுக்கு கால் பண்ணி சொல்றேன் சரி ஓகே அதுதான் எவ்ரிதிங்
and what
was such an inspirational discussion
அபிரங்க மேடம் இல்லையே அபிரங்க மேடம்
then Murtila
என்ன ஃபீட்பேக்
எப்படி கொண்டு போறோம் ஏதாவது
அது வந்து ஆர்கனைஸ் செக்ரட்டரி இஸ் கோயிங் ஆன்
inaugural party அப்ப எல்லாரும் சேம் கலர் பிங்க் வித் அந்த இதெல்லாம் ஏதாவது அரேஞ்ச் பண்ணாங்க
காஸ்டியூம் ஐ திங்க் ஐயோ எல்லாரும் I don't
one person initiate பண்ணிட்டு
I'm not also thinking right
pink sorry
stop please
அவங்க வந்து மேடம் வந்து ஒவ்வொருத்தருக்கும் மெசேஜ் அனுப்பிச்சு கலெக்ட் பண்ணி for Muthu madam.
I think meeting close to
Actually,
inaugural for her. She's outside. Sure, sure, it is there for her.
So what we will do is, every one of us will contribute something. We'll ask Radha madam, treasurer, we'll start the work. Let her collect from everybody.
Target amount.
How many will be there? அது வந்து ஒரு particular amount madam should collect and then buy something.